Well, Dr. Nadeem, we've been hearing the term personalized medicine more frequently in recent years. How would you define personalized medicine for myeloma, and how can patients access this type of care?
Yeah, personalized medicine or precision medicine, is a term that we've really sort of used for many oncologic conditions, over the last decade or so. I would say for multiple myeloma, in terms of identifying a target within the myeloma cell that's unique to the patient and then deploying a certain therapy to that patient because of that target is still lacking. We do have, one example where patients have, for example, an 11-14 translocation, which we see in about 15% of myeloma patients. There's an agent called venetoclax that is very active against that particular cohort of patients, although that is still not approved to be used. But that's one example where that agent specifically benefits that type of myeloma. Other than that, most of the therapies that we have benefit essentially everybody with myeloma, which is great, but it's not so personalized. Where I would say there's most personalization happening now, at least in my practice, is looking at which types of therapies an individual patient may receive. What I mean by that is if somebody's in an excellent response with quadruplet-based induction therapy, I have a very real discussion with them about the pros and cons of stem cell transplant. We make those decisions in real time, depending on how the patient is doing, depending on how their response is, and then kind of deciding as a whole, kind of what are the risks and benefits and what makes sense for that individual patient. Similarly, when you go on to maintenance therapy, maintenance therapy means that after you've gone through the initial phase of your myeloma therapy and the disease is under control, what type of therapy can we keep you on to keep it under control for as long as possible? Historically, that has been lenalidomide or Revlimid. Now we're adding drugs such as daratumumab and other agents to Revlimid to see if that can further prolong the response to that initial therapy. So all those decisions are so individualized that you have to discuss with your provider, what makes sense for you and what are the pros and cons of doing one approach versus the other.
Well, if we're talking about in-depth testing, how do the results of that testing affect treatment options?
So right now we use, conventional blood tests to get a sense of response in vast majority of patients. That includes the serum protein electrophoresis and the serum free light chain assay. Most patients have detectable levels of these proteins, abnormal proteins in the blood at diagnosis, and then you can follow them using a blood test. There's a subset of patients that have disease only that shows up on scans. So we then, kind of incorporate some of those scans and then also utilize the bone marrow results, both from the beginning and then subsequent analyses to kind of give a big picture composite response assessment for that particular patient. Nowadays, there's also other tools that we're using, such as MRD or minimal residual disease. That is a test that is done on a bone marrow biopsy to determine if you don't have detectable protein in the blood, do you have myeloma cells present at the deepest level possible? And if you do versus if you don't, trials have shown that there is a difference in terms of prognosis. Now, while that hasn't fully been utilized yet to make treatment decisions in patients that are not on clinical trials, we do get prognostic information out of it. And nowadays, more and more of those trials are using these MRD tests to determine what to do with treatment. And I think that's how it's going to be in the future. So, having those extra tests available, but again, important to discuss with your provider, what is the utility of this test? How are we going to use this information for your individual case to make some decisions?